Welcome to today's webinar. My name is Jose Francisco, Project Manager at the IAS USA. Today's webinar will be going over managing gonorrhea and its complications, a case-based approach. I'd like to welcome Dr. Khalil Ghanem from the Johns Hopkins University School of Medicine. Welcome, Dr. Ghanem.
Thank you, Jose. It's a pleasure to be here. Thank you so much for joining us, and thank you to IAS for inviting me to talk about gonorrhea. When we decided on the topic 4 or 5 months ago, the guidelines still hadn't changed, and so it's fortuitous that we're talking about gonorrhea because the guidelines very recently, just a few weeks ago, changed, and the CDC released some new guidelines for gonorrhea. So it's perfect timing. Thank you so much, everyone, for joining us. And I'm going to go through some housekeeping issues initially, and then we will start with presentation of the slides, the formal slides. So let's start. Let me first make sure that I can move this. Yes, I can. So CME information, ladies and gentlemen, you'll be getting 1.25 AMA PRA category 1 credits for CME. In addition, there are other continuing medical education points that you get that are listed here, including ABIM mock points. And instructions for claiming credit will be emailed to you after the webinar. These are the supporters who have provided grant support for this webinar, and we appreciate their support. And here's how you're going to navigate the webinar. For poll questions, you're going to have a separate window that's going to show the poll question. Choose your response from the poll, and then the responses will be displayed after the poll closes. Asking questions, we absolutely welcome it. I'm going to be answering questions at the end of the webinar. There's going to be 15 minutes to answer questions at the end of the webinar. All you have to do is enter using the Q&A button. Please make sure that your first and last name are indicated so that your question goes through. Again, we will answer the questions at the end of the webinar, and I will do my best to go through most of these questions. So here's poll number 1, and it's going to give us a sense of who our audience is. So please indicate the number of patients you tested for gonorrhea in the last month. A is 0, B is 1 to 5 tests, C is 6 to 10, D is 11 to 50, and E, if you work in an STI clinic, it's greater than 50. So please answer the poll. Ooh, fantastic. So it looks like, well, it looks like about a third, less than a third, did not test for gonorrhea. If we had asked over 3 months, I bet we would have gotten some more people who are testing. But it's great that we have about 20% that are working at a high testing site and even moderate testing sites. So pretty amazing. Thank you very much for answering that question. It's helpful to know who the audience is. And so, again, we're going to continue. And this is me again. And we're going to go to a couple of pretest questions. Now, with the pretest questions, we're not going to provide you with the answer immediately, but we will provide you with the answer at the end of the webinar. And hopefully the webinar itself will answer some of these questions for you. And so here are our learning objectives. We're going to describe the epidemiology of gonorrhea, including drug-resistant gonorrhea. We're going to develop an approach that optimizes the diagnosis of urogenital, extragenital, and also don't forget disseminated gonococcal infection, including infections caused by suspected drug-resistant strains. And finally, we're going to define the optimal approach to treating gonococcal infections, including infections in penicillin allergic patients. We're going to highlight that during this webinar. And of course, in persons living with HIV. So those are our learning objectives, and I'm going to do my best to make sure that I satisfy those objectives. So ladies and gentlemen, get ready for the pretest question number 1. A 38-year-old woman presents for a routine visit. She's doing well. She has no symptoms. She does report condomless penile vaginal exposure with a new sex partner 1 week earlier. Her physical exam is completely normal. A self-collected vaginal swab is sent for gonorrhea and chlamydia NATS testing, nucleic acid amplification testing. 2 days later, the results are reported. So she's found to be NAT positive for gonorrhea. She has gonorrhea, but NAT negative for chlamydia. So she does not have chlamydia. Which of the following is the most appropriate treatment regimen? Azithromycin 1 gram orally and ceftriaxone 250 milligrams intramuscularly, azithromycin 2 grams orally, Suffixine 400 milligrams orally, Ceftraxone 500 milligrams orally, intramuscularly, or Genomycin 5 mg per kg intramuscularly with 2 grams of azithromycin orally. So what is the best treatment regimen for her gonorrhea infection? Again, we're not going to show you the answers until the end of the session. Fantastic. Thank you for voting. All right, I can see the answers. It's good that we're having the webinar. I'm delighted. So that's good. And so I'm going to move on to the next and final question. Pre-test question. So a 23-year-old man reports receptive oral penile condomless exposure with a new same-sex partner. He denies any other exposures or symptoms. His physical exam is completely normal. A nucleic acid amplification test for gonorrhea of the throat is positive. Which is the most appropriate management approach? So he's got pharyngeal gonorrhea. What should you do? Should you do ceftriaxone intramuscularly and treatment of the sex partner? Ceftriaxone intramuscularly, rescreen in 3 months and treatment of sex partner. Ceftriaxone intramuscularly, a pharyngeal test of cure in 1 to 2 weeks and treatment of sex partner? Or should you do ceftriaxone intramuscularly, a pharyngeal test of cure in 1 to 2 weeks, rescreen in 3 months and treatment of sex partners? Please vote, and we're going to cover all of these things in today's webinar. Fabulous, excellent. Again, I'm glad we're having this webinar because there was a lot of diversity in the answers. I'm not going to tell you the answer just yet. All right, thank you very much for participating in this. Now you can sit back, relax. There are not going to be any more poll questions or questions until the end of the webinar. We're going to get started with the talk. And so we're going to start with Henry. And Henry is going to be our patient who's going to follow us throughout this webinar. And here's his story. He's a 34-year-old man who presents for a routine clinic appointment 6 months after his last visit. So you last saw him 6 months ago. He's doing very well and he has no complaints. His HIV was diagnosed 4 years earlier. He's currently taking antiretroviral medications and his CD4 count is 660 cells and he has an undetectable HIV RNA. He has a history of secondary syphilis that was diagnosed and treated at the time of his HIV diagnosis 4 years earlier. At the last visit, that is 6 months ago, he was screened for gonorrhea, for chlamydia, and for syphilis, and everything was negative at the time. From the social history standpoint, he does not smoke. He usually drinks 2 mixed alcoholic drinks per night on average, but more on certain weekends. No other substance use at all. He's married, but he's in an open relationship with his husband. He's had 3 other same-sex partners in the last 6 months. He says that he uses condoms consistently when not with his husband, and he practices receptive anal and oral sex. His physical exam is unremarkable. The anogenital exam is normal, no skin or mucosal lesions whatsoever. So Henry's doing well. He's here 6 months after his last visit. At the last visit, he was tested for gonorrhea and chlamydia and syphilis, and they were negative. So Henry is going to follow us throughout our course today. So what are the symptoms caused by infection with Nyseri gonorrhea, and how often are infections asymptomatic? So that's going to be our first question that we're going to answer. And so these are the signs and symptoms of Nyseri gonorrhea infection. In men, usually after an incubation period of 2 to 8 days, the men present usually with a urethral discharge or dysuria. Rare complications include penile lymphangitis, periurethral abscesses, urethral strictures over time, and about 30% of cases of epididymitis in young men are caused by Nyseri gonorrhea. The other 70% are caused by Chlamydia trachomatis. As men get older, the more common causes of epididymitis become gram-negative enterics like E. coli. In women, symptomatic women may experience a vaginal discharge. Usually it's an endocervical discharge, but what a woman notices is the vaginal pooling of these endocervical secretions, and they refer to it as a vaginal discharge. Occasionally they'll have vaginal pruritus, intermenstrual bleeding, or menorrhagia. They occasionally may have abdominal pain and dyspareunia, and please be careful not to miss pelvic inflammatory disease. So in women who have abdominal pain or dyspareunia, you should perform a bimanual examination to make sure that you don't miss pelvic inflammatory disease. Also remember gonococcal conjunctivitis, which occurs in infants born to infected mothers, but in adults, it's frequently the result of auto-inoculation, but there have been outbreaks secondary to non-sexual transmission which have occurred. So keep in mind gonococcal conjunctivitis. Now, we've talked about the common symptoms associated with uncomplicated gonorrhea and chlamydia. With uncomplicated gonorrhea. We're going to talk about disseminated gonococcal infection in just a bit. But how often are these infections asymptomatic? How often do these infections not cause symptoms? Well, in women, urogenital, pharyngeal, and rectal infections, the majority of these infections are asymptomatic. In men, the vast majority of pharyngeal and rectal infections are asymptomatic. So please keep in mind that in both women and in men, pharyngeal and rectal infection, the vast majority, up to 90 to 95% of these infections may be asymptomatic. So if you're asking about symptoms, you're missing the vast majority of infections. In women, urogenital infections, in the majority of women, are asymptomatic up to 85%. Believe it or not, in men and urogenital infections, there's still a debate about whether these infections in men are symptomatic in the majority of patients or asymptomatic in the majority of patients. There are some experts that feel that the majority of infections, urogenital infections in men are symptomatic, whereas a bunch of other experts in gonorrhea say no, they're probably asymptomatic. I tend to believe that the majority of infections among men are asymptomatic. There are population-based studies that have gone out in communities that have looked for gonorrhea and have found it, and the majority of these men were asymptomatic. So right now, there's no formal answer. My take is that many, many men are asymptomatic who have urogenital gonorrhea. And so again, please remember, don't necessarily just ask about symptoms, also ask about exposures, because otherwise you will miss the majority of these infections. Now, disseminated gonococcal infections has made a comeback in the United States. There have been outbreaks of DGI that have been reported from the Midwest, but also on the East Coast as well as the West Coast. So please keep in mind disseminated gonococcal infection and the clinical manifestations, because if you miss it, this infection, the disseminated gonococcal infection, can essentially lead to death. And so you don't want to miss these infections. The typical manifestations include either the arthritis dermatitis syndrome, and that's characterized by tenosynovitis, dermatitis, and I'll show you the pictures down here, polyarthralgias with or without purulent arthritis. Most cases don't have purulent arthritis, they just have polyarthralgias. But in some cases of the arthritis dermatitis syndrome, you will have frank purulent arthritis. On the other hand, the other manifestation is simply purulent arthritis, mono or an asymmetrical oligoarthritis of the distal joints, particularly affecting the knees, the wrists, and the ankles. So if you have somebody that comes in with a monoarticular or oligoarthritis that's asymmetrical, please think about the possibility of disseminated gonococcal infection. Don't miss it. And in rare cases, you can see this accompanied by endocarditis, meningitis, myositis, and osteomyelitis. And so in these pictures here, you can see the dermatitis part of the arthritis dermatitis syndrome. You see these well circumscribed reddish pustular lesions. There are usually about 6 to 12 lesions that develop on the distal extremities. So make sure you look carefully at the ankle and at the wrists as well. Here you see evidence of these lesions, but also this patient had a frank arthritis. And here you see the gram-negative diplococci that are seen on the Gram stain. So please keep in mind disseminated gonococcal infection. It's making a comeback, and these are some of the clinical manifestations that you should be looking for. So the question now is that should Henry be screened again for Nyseri gonorrhea? So let's go back to Henry. Remember, he was last screened 6 months ago. He was negative for gonorrhea, chlamydia, and syphilis. And now he comes back for a well visit, essentially. He's asymptomatic. But remember his social history. He is married, but he's in an open relationship. He does report that he uses condoms with his non-monogamous, well, with his partners that are not his husband. And so the question becomes, should we screen Henry again? Excuse me. And so to answer that question, ladies and gentlemen, we are going to have to talk briefly about the epidemiology of gonorrhea. And so the data that we have here that I'm presenting are from 2018. The 2019 data, which usually come out in October, have been delayed by COVID, but the CDC assures us that it will be released in the first quarter of this year. So keep a lookout for the 2019 data. But based on the 2018 data, what we know is that gonorrhea reached a nadir low in the United States in 2009. It was the lowest cases of gonorrhea that were ever reported. And then since then, the rates have been going up. The rates have been going up in both men and women, men higher than women. And among men, excuse me, many of the cases have been among men who have sex with men. So again, we're seeing increases since 2009 among both men and women, more pronounced among men, and among men, it's been particularly pronounced among men who have sex with men. Now, if you look at the age distribution of these infections, the majority of these infections, just like chlamydia, tend to occur in those who are younger. So the 15 to 19 age group are particularly affected. But if you look across the age groups, it's never zero. And so even in older patients, gonorrhea is still prevalent. And so keep that in mind as well. And then by race ethnicity, gonorrhea, the rates are highest among Blacks, but you can see here the distribution amongst the various races and ethnicities that are described in this chart. Now, what about disseminated gonococcal infection? Again, one of the attendees has said we had a DGI cluster in West Michigan last year. That's exactly right. There have been clusters throughout the United States reported. This was a notes from the field in the MMWR. There's an ongoing cluster of highly disseminated gonococcal infections in Southwest Michigan. And in Southwest Michigan, in this particular cluster, it was linked back to a group, a network that was using methamphetamines. But what was also very interesting about this cluster is, one, it was mainly the male predominance, but almost half-half. The vast majority of patients presented with a septic arthritis picture. Excuse me. And I promise you, I don't have COVID. But they came in with a septic arthritis picture, and they also had myositis, tenosynovitis, and osteomyelitis. They were diagnosed with gonococcal infections at the urogenital site in 50%, but also pharyngeal in 30%. So please keep in mind that when you have somebody who has disseminated gonococcal infection, you suspect has disseminated gonococcal infection, make sure you test them at all potential mucosal sites, urogenital, pharyngeal, and rectal. It is critical so that you don't miss your ability to diagnose that infection. And then nearly all of them were hospitalized, and the vast majority got ceftraxone treatment initially parenterally. And then, of course, 63% were using methamphetamine in this particular cluster. Other clusters have not necessarily been linked back to particular drug use. I want to remind you too, so there have been clusters throughout the United States. Keep an eye out open for your for disseminated gonococcal infection. But I also want to remind you that Nyserial infections tend to occur as a result of complement deficiencies, either inherited or acquired. Remember, the terminal complement deficiency is strongly associated with increased risk for Neiserial infections, both Neisseria gonorrhea and Neisseria meningitidis. And so in this case series, they used eculizumab, which essentially inhibits the complement pathway, and they saw gonococcal infections in those patients, not surprisingly, who were receiving eculizumab. So keep in mind terminal complement deficiency and the risk for gonococcal and meningococcal infections as well. So that's DGI epidemiology. You have to suspect it, and if you miss it, those patients can have a very poor outcome. So be very careful. Do a good physical exam on your patient. So the next question that comes up is, who should be screened for Neisseria gonorrhea, and how often should they be screened? Remember our patient Henry, he was just screened 6 months ago. Should we screen him again? And so I made a table that I hope you'll find useful, looking at the various populations: women, MSW, MSM, people living with HIV, pregnant women, women on PrEP, MSW on PrEP, and MSM on PrEP. And hopefully it gives you a sense of who should be screened. And if we look at persons living with HIV and MSM, the recommendation from the various bodies that make recommendations, including the CDC, HIV-MA, USPSTF, they vary. And I tried to sort of summarize the main recommendations in this table. But remember, with people living with HIV, the recommendation is at least annual screening. And among your MSM, at least annual screening. I hate that term, at least, and then annual screening, because people always forget at least, and they just do annual screening. So please remember that there are 2 words before annual screening, and those 2 words are at least. And keep in mind that at least means that if your patient has certain risk behaviors that put them at risk, at increased risk for acquiring this infection, you should be screening them more frequently. And in fact, in some cases, you should be screening them at least, well, you should be screening them on a quarterly basis. And so what are some things to keep in mind in terms of risk factors? Multiple sex partners, a recent STI diagnosis, the use of drugs such as meth, but also alcohol that are associated with sex. And so please keep in mind that in your patients that endorse higher risk behaviors, you should be screening them much more frequently. And so our patient, Henry, does endorse some high-risk behaviors. And so I think that Henry would be a candidate for more frequent screening. And I think that's perfectly reasonable. So again, also remember, and we're going to talk about this separately, that when we say screening, we're actually testing individuals who have no symptoms. And when we say screening, we're also endorsing screening of extragenital sites like the throat and the rectum among certain populations. And we're going to talk about that in an upcoming slide. So should Henry be screened again? Well, he is a man living with HIV, and he's also MSM. He endorses certain behaviors that put him at higher risk for acquiring gonococcal infection, as well as chlamydia and syphilis. And so in this case, I would argue that Henry should be screened on a quarterly basis for gonorrhea, chlamydia, and syphilis. So again, these are the recommendations that are summarized. So a decision is made to screen Henry for Neisseria gonorrhea. Which anatomical sites should be targeted for screening? And so here we're going to talk about anatomical sites and gonorrhea infections. And in women, this is a very nice systematic review that was published by Phil Chan and his group. And what they did was they looked at all of the data that were published on extragenital infections with gonorrhea and chlamydia in both women and men, including MSM and MSW. And what they found was that, of course, the prevalence of these infections at the throat and the rectum was highest among MSM. We knew this. And in fact, there are some data to suggest that up to 70% of infections among MSM, gonorrhea infections among MSM, would be missed if you only screen the urogenital site. If you only sent urine for gonorrhea testing, you would miss up to 70% of infections among MSM because they tend to occur either in the throat or in the rectum. And remember, the majority of those infections are asymptomatic. So the patients will not complain of symptoms. But keep in mind that, and that's why there are formal recommendations for MSM to screen at all sites of exposure. There are not formal recommendations to screen women and MSW at all sites of exposure, but keep in mind that the prevalence of these infections among women and MSW is not zero. In fact, a significant number of infections do occur at the rectum, at the pharynx in both women and MSW. But because the relative prevalence is lower in these two groups, and because screening is associated with cost, there are no formal recommendations to screen MSW and women. It doesn't mean you shouldn't do it in the right person. So if a woman or a man who has sex with women endorses exposures at the rectum or at the throat, you definitely should screen them there. But there are no standing recommendations. That's the big difference. People get confused. They say, I don't test my women at the throat and the rectum, even if they've had exposures, because there are no recommendations. That's not the case. You should probably be testing, you should be screening at the throat and at the rectum in women and MSW who endorse exposures at those sites. But among MSM, there are standing recommendations to screen at all sites of exposure. So please keep that in mind, because otherwise you will miss 70%. In women, the data suggests that you might miss up to 30% of gonococcal infections if you only do urogenital testing, but that varies significantly among the populations that are being tested. So the take-home message here is that we should be screening. We should not forget about the throat and the rectum when we're screening our patients for gonorrhea. And in the right patient, you should be screening at all mucosal sites. So what are the appropriate specimens to use when screening or testing a patient for Nyseri gonorrhea? This is going to be important because we are essentially, when we're testing, you can screen using gnats, which are the best screening tests by far. But we still sometimes need to use culture. So it's important to know which specimen to use when we're screening. So here's another table that I hope you'll find useful. And in summary, if you're using a gnat test to screen, you can use a gnat test to screen using different specimens. In men, the preferred specimen is a first catch urine specimen to send for gnats testing for gonorrhea and chlamydia, but you can also send a urethral swab to test it for Nyseri gonorrhea and chlamydia trachomatis. In women, if you're using a gnats test, you have a lot of options. You can use a vaginal swab, either a clinician collected or a patient collected vaginal swab, self-collected vaginal swab. That's the preferred specimen. But if you happen to have an endocervical swab, you can also send it for gnats testing. You can send first catch urine for gnats testing in women as well. That's acceptable. And if you're doing liquid pap, you can send that for gonorrhea and chlamydia as well using gnats. So in women, lots of option. The preferred one is a vaginal swab, but you can use any of those for gnats testing. For extragenital testing, the best tests are gnats, and they are essentially compared to culture. Culture is only 50% sensitive as compared to gnats at extragenital sites. So gnats are by far the best test, and they are now FDA cleared for testing for gonorrhea and chlamydia at the throat and at the rectum. So they are FDA cleared for testing gonorrhea and chlamydia at the throat and the rectum, and they are the best tests to use at the throat and at the rectum. And so that's great for gnats. For cultures and gram stains, remember, this is very important. The only recommended specimens in men is a urethral swab. Urine is not appropriate for culture. So if you need to send a culture for gonorrhea in a man, you have to get a urethral swab as your specimen. Urine is not acceptable. In women, the only acceptable specimen for culture for gonorrhea is an endocervical swab. A vaginal swab is not as good, and urine is not as good and should not be used for culture. So please keep in mind that for cultures and gram stain, you have to get a urethral swab in men or an endocervical swab in women. For gnats, you have lots of options: urine, urethral swab, vaginal swab, self-collected, including lots of options for gnats. You can also get a culture from the throat and the rectum. Remember, though, that culture is only about 50% as sensitive as nucleic acid amplification tests. So you might say, why the heck would I get cultures since gnats are so much better at all the sites? You still need to get cultures to detect antimicrobial susceptibility testing. So if you want to know what this organism is sensitive to, clinically, you still need to get cultures to be able to identify susceptibility patterns. So that's the only time that I usually get cultures, is when I'm interested in finding out what this organism is susceptible to. So these are the specimens that are used. Are patient self-collected swabs appropriate specimens to obtain? Yes, for nucleic acid amplification tests. There have been multiple studies that have shown that self-collected vaginal swabs, self-collected throat swabs, and rectal swabs performed comparably to clinician-collected specimen when using gnats to diagnose Nyseri gonorrhea. So self-collected swabs or a self-collected first catch urine, of course, are absolutely great specimens to use when you're using gnats. But remember, for culture, you still need to get a urethral specimen, and you still need to get an endocervical specimen. And for those, usually a clinician-collected specimen is usually preferred. Now, there was a small study that looked at that, and it was done by Lindley Barbie and their group in Seattle. And what they found was essentially that self-collected specimens performed comparably to clinician-collected specimens when using cultures to diagnose Nyseri gonorrhea. It was a small study, but remember, they're not saying that culture is better than gnats. They're just saying that the specimens used to collect for cultures performed just as well when the patient collected them as when the clinician collected. So it's an important study, but remember, gnats for sensitivity are the way to go in most cases. And so let's go back to Henry. He was screened at all sites of exposure. So remember, we decided to screen Henry, and we screened him at the throat, at the rectum, because he's had exposures there, and at the urogenital sites. And this is what comes back. His first catch urine was positive, and his pharyngeal gnats were also positive. So he had gonorrhea in the throat and in the urethra. And so the next question is, what's the most appropriate regimen to treat his urogenital Nyseri gonorrhea infection? So to treat his infection in the urethra, what should we use? And this is where the guidelines have changed. In December, the CDC has released new guidelines for the treatment of gonorrhea. Nobody is surprised. We were using Ceftraxone plus Azithromycin in patients to treat gonorrhea since 2015 consistently. And then the dose of Ceftraxone went up from 125 to 250 milligrams with a gram of Azithromycin. But over time, unfortunately, the emergence of macrolide-resistant gonorrhea has become a reality. Just under 5% of the strains of Nyseri gonorrhea that were detected in the United States in 2018 had high MICs to azithromycin. And as a result, azithromycin has become less efficacious for the treatment of gonorrhea. Luckily, the strains are mainly sensitive to ceftriaxone, and so the CDC has changed its recommendations. And in December of 2020, there was an update to the treatment recommendations by the CDC. And again, this is essentially showing azithromycin resistance that has developed over the last few years. And now almost 5% of the strains, the prevalent strains, are actually have high MICs to azithromycin. And in some populations like MSM, the prevalence is even higher. It's closer to 7%. And so azithromycin high MICs to azithromycin are becoming much more commonplace. And as a result, the CDC said, okay, we're going to abandon the use of azithromycin for the treatment of gonorrhea, and we're going to bump up the dose of ceftriaxone. So the new recommendation from the CDC to treat uncomplicated gonorrhea of the urogenital tract and the rectum is 500 milligrams IM of ceftriaxone, up from 250 milligrams, 500 milligrams of ceftriaxone as a single dose for persons who weigh less than 150 kilograms. And if they weigh more, then you should use a gram of ceftriaxone. So now ceftriaxone is the only drug to use to treat gonorrhea, but it's a higher dose of ceftriaxone. If you have not ruled out chlamydia, or if the patient has chlamydia, then you should use doxycycline 100 milligrams twice a day for 7 days to treat the chlamydia. So again, gonorrhea, if you know the patient doesn't have chlamydia because you have a test that tells you the patient doesn't have chlamydia, then you can just treat with ceftriaxone, 500 milligrams times 1 dose IM. If you don't have the results of chlamydia testing, or if the patient does have chlamydia, then the treatment is with doxycycline for 7 days, 100 milligrams twice a day. Now, if you can't use ceftriaxone to treat gonorrhea for urogenital and rectal infections, do you have other options? You do. You can use the combination Genomycin plus 2 grams of azithromycin. That's still a possibility. Or you can use Suffixine, but not at the 400 milligram dose, at the 800 milligram dose. So either use high dose Suffixine 800 milligrams as a single dose, or a combination of Genomycin plus azithromycin. Those are the alternate options to treat urogenital infections. And so why did the CDC change the dual treatment regimen recommendation? And why did they increase the dose of ceftriaxone? So why did this happen? Very simply for several reasons. First of all, for the sake of antimicrobial stewardship. Using fewer antibiotics makes more sense because you're exposing a population to fewer antibiotics and therefore decreasing and mitigating the emergence of antimicrobial resistance. So they said, you know what? These infections are susceptible to ceftriaxone, and so we're going to use ceftriaxone alone to treat gonorrhea. Also, of course, they let go of azithromycin. Another reason is because of increasing azithromycin resistance in the community. So it made sense to leave azithromycin behind, and that's what they did. And then they also looked at ceftriaxone. So why did they increase the dose of ceftriaxone? Why not keep it at 250 milligrams? Why did they increase it to 500 milligrams? Because they looked at recent data that have come out, animal models, and they saw that in animal models, you need 5 milligrams per kilogram to achieve appropriate concentrations of ceftriaxone to treat gonorrhea. And so that equivalent of 5 milligrams per kilograms in humans is in most cases, when you have, let's say, a 60, 70, 50 kilogram person, it's equivalent to 500 milligrams. 250 milligrams was too low. And so to optimize the dosing of ceftriaxone to treat gonococcal infections, 2, for the sake of antimicrobial stewardship, and 3, because of increasing macrolide resistance, for urogenital and rectal infections, the recommendation now is 500 milligrams of ceftriaxone as a single IM dose. That's the new recommendations for those infections. But what about his pharyngeal infection? How do we best treat his infection in the pharynx? And this is also a change, ladies and gentlemen. And so they recommend ceftriaxone 500 milligrams IM as a single dose for pharyngeal infection. But what's the difference? The difference is that they don't recommend any alternative agents other than ceftriaxone for pharyngeal infections, because there are no reliable alternative treatments for pharyngeal gonorrhea beyond ceftriaxone. And so that's really important. That's a change. And so for patients who have a history of a beta-lactam allergy, don't give up on ceftriaxone. And we're going to talk about that in just a bit. Because the other options that we have, Suffixine 800 milligrams, not good enough. And Genomycin, not good enough for pharyngeal infections. I'm going to show you some data on the next slide. So if you have somebody who has an infection in the urethra, or in the rectum, you have options. You can use Ceftriaxone, which is the best one, and I would recommend that you use Ceftriaxone preferentially. But if for some reason you can't, you can use a combination of Gent and Azithromycin or high-dose Suffixine. But for pharyngeal infections, you absolutely have to use Ceftriaxone. And so let's talk about the treatment guidelines for pharyngeal infections. How do they change? So not only did they say you can't use any alternative agents beyond Ceftriaxone, they also said that whatever you use to treat pharyngeal gonorrhea, Ceftriaxone or some other regimen which we don't recommend, go ahead and plan for a test of cure 7 to 14 days after the initial treatment. So if you're seeing Henry today and you say, Henry, I'm going to treat you for this pharyngeal infection with 500 milligrams of Ceftriaxone IM, but you need to come back in 7 to 14 days, in 1 to 2 weeks, and I'm going to do another test of your pharynx to make sure that you cleared the infection. So you can do a test of cure with either a NAT or a culture. And in some cases, if you suspect that there is drug resistance, probably doing both the NAT and the culture makes sense. Now, for expedited partner therapy, the partner may be treated with a single 800 milligram oral dose of Suffixine, provided that concurrent chlamydial infection in the patient has been excluded in your index patient. Otherwise, the partner may also be treated with a single dose of Suffixine, 800 milligrams, not 400, plus oral doxy for 7 days. So again, if you tested Henry for chlamydia and he was negative and you wanted to treat Henry's partners, you could use 800 milligrams of oral Suffixine. If you don't know what Henry's status is with chlamydia, you can do EPT for the partner using both oral Suffixine and oral doxycycline. And remember that everyone that you treat today with gonorrhea or chlamydia or syphilis, you need to rescreen them 3 months after treatment. Always, everybody that gets tested today for gonorrhea, chlamydia, trichomoniasis, or syphilis, bring them back in 3 months to rescreen them because the reinfection rate is very high. So now keep in mind, ladies and gentlemen, for pharyngeal infections, right? For pharyngeal infections, you have to treat with Ceftriaxone. You have to get the patient back in 1 to 2 weeks and do a test of cure. You have to treat the patient's partner with the appropriate drug or combination of drugs if you haven't ruled out chlamydia. And you have to bring the patient back 3 months later and rescreen them. There's a lot to be done when you diagnose patients with pharyngeal infection. If you diagnose them with just a rectal or urethral infection, you treat them today, you treat their partners, and you bring them back in 3 months for screening. You do not have to do a test of cure for urethral and rectal infections. So I hope that's clear. Significant differences there. And so why does the CDC only recommend Ceftriaxone for pharyngeal gonorrhea? And why do they want a test of cure? What's the deal? Why are they doing all of this? And the answer is because of this. It is clear that Ceftriaxone concentrations tend to be more variable in the pharynx, and that the treatment of Nyseri gonorrhea in the pharynx probably requires longer time above the strain's MIC. So because Ceftriaxone, even Ceftriaxone, which is one of the better drugs that we have, because their concentration tends to be more variable in the pharynx, it's important to do a test of cure to make sure that you are able to eradicate the pharyngeal infection. So that's one. Two, when looking at why not recommend high-dose Suffixine? Well, because 800 milligrams of Suffixine, single dose, did not achieve consistent concentrations in the pharynx. They did not achieve consistent. In fact, you needed to dose Suffixine 800 milligrams 3 times in 24 hours to achieve some concentrations in the pharynx. So clearly, Suffixine for pharyngeal infections at 800 milligrams once is not appropriate. Similarly, there have been at least two studies that show that Gentlemycin is not the most reliable drug to treat pharyngeal infections. So what are you stuck with, ladies and gentlemen, for pharyngeal infections? You're stuck with ceftriaxone. You're stuck with ceftriaxone. That's the only good option that you have. If you can't use ceftriaxone, the CDC recommends that you call an ID specialist. What is the ID specialist going to tell you? Most likely they'll say use the Genomycin 2 gram of azithromycin dosing and do a test of cure in 1 to 2 weeks to make sure that you are able to eradicate it. But here the big question is, who are the patients in whom you should not use ceftriaxone? And this is a really important question. What's to be done if a patient reports a penicillin allergy? What do you do with a penicillin allergy? The first step is stop. Don't abandon ceftriaxone when a patient tells you, oh, I have a penicillin allergy. Get more information about the nature of the patient's penicillin allergy. It is critical that you get more information. The vast majority of patients who report a penicillin allergy, I'm talking here 90+%, can be safely treated with ceftriaxone. And I'm going to show you some data. First of all, the nature of the penicillin allergy. Ask the patient, what did you get? When you took penicillin, when did it happen? And what are the symptoms or signs that happen? Very often they'll say, oh, I don't remember. My mom told me when I was a kid, I had a reaction to penicillin. And so keep in mind that 80% of patients with IgE-mediated penicillin allergies have lost that allergy after 10 years. They're not allergic anymore. So please keep that in mind. The other thing you have to assess is whether this is an IgE-mediated immediate in onset or whether it's T-cell mediated delayed in onset. There's a big difference there. The immediate onset, of course, they usually present with an urticarial rash. They can present with itching, flushing, angioedema of the face, extremities, difficulty breathing, wheezing, and hypotension. Those are the classic manifestations of a IgE-mediated immediate type hypersensitivity. Those are scary. And if they tell you that they've had this kind of reaction and they describe it well, and it's been in the last 10 years, that's when you should sort of say, okay, I should be a little bit concerned. Now, what about delayed reactions? Those mainly tend to be rashes, different types of rashes, maculopapular, contact dermatitis, rarely Stevens-Johnson syndrome or DRESS syndrome, and sometimes they can present as drug fevers. Of course, I would be worried about SJS or DRESS. If they say I had Stevens-Johnson syndrome, of course, you're going to be very careful. But for the majority of the patients who report an IgE-mediated or a T-cell mediated reaction, getting more information helps you to determine the validity of these reactions and whether you can safely use ceftriaxone or not. So usually I'll start by saying, what kind of reaction did you have? And then the next questions I ask, if they tell me, you know, I had, let's say, wheezing when I used penicillin 12 years ago. I'll say, okay, fine. Have you taken amoxicillin since then? No. Have you taken Augmentin since then? I don't remember, maybe. Have you taken Keflex? Yes, I took Keflex 2 years ago. Excellent, use ceftriaxone, you're going to be fine. And so asking basic questions from the patient will help you determine if you can use ceftriaxone or not. In the majority of these patients, you can use ceftriaxone. This is really, these are interesting studies that have been done, looking both at IgE-mediated and T-cell mediated. And what they found was that in individuals who had a T-cell mediated reaction to penicillin, the vast majority of these individuals were able to tolerate ceftriaxone without any problem because it had different side chains. The antigenic determinants are very different. Similarly, with IgE-mediated reactions, they did testing, skin testing for ceftriaxone, and what they found was that the vast majority of individuals who had documented IgE-mediated reactions to penicillin were still able to tolerate ceftriaxone. And so the third generation cephalosporins have unique, distinct antigenic determinants that make them safe to use in most patients who report a penicillin allergy. So please don't assume that a penicillin allergy means that you can't use ceftriaxone. Ask additional questions and then make a decision. For the vast majority of these patients, you can still use ceftriaxone. So Henry returns for his test of cure 2 weeks later. His pharyngeal gnat is still positive. What's the next step? So now you're like, okay, Henry, I treated him with ceftriaxone. He comes back and his pharynx is still positive for gonorrhea. What are the possibilities? Stop. In most cases of persistent infections, they're due to reinfection rather than treatment failure. So the possibilities are either it's a false positive nucleic acid amplification test, but usually by 2 weeks, you shouldn't have a false positive. So that's less likely. The two more likely possibilities are Henry got reinfected, or Henry essentially was not adequately treated with ceftriaxone. What should you do? If Henry says, yes, I've had an exposure since the last time I saw you, just treat him again with ceftriaxone, 500 milligrams, and bring him back with it for a test of cure in 1 to 2 weeks. But if Henry says, I swear I have not done anything since the last time I saw you, at that point, if the patient denies any intervening exposures, you should obtain another gnat and a culture. And the reason to get a culture is because you can get antimicrobial susceptibility testing to figure out if this organism is resistant to ceftriaxone, and more importantly, to figure out what other drugs you can use to potentially treat Henry. And so while you're waiting for the test results to come back, you can choose to either treat him with ceftriaxone 500 milligrams again, or you can choose to treat him with Azithromycin, Gentlemycin, but it's important to bring him back for a test of cure. At that point, hopefully, you will have a culture result that will tell you what the drug susceptibility pattern is. So if you find somebody with an antimicrobial susceptibility pattern that suggests resistance to ceftriaxone, call your local health department immediately. They need to be informed immediately so they can inform the CDC and measures can be undertaken, because that's going to be a mess when it first happens. How is disseminated gonococcal infection managed? First of all, get a good history and physical examination because it's going to be a clinical diagnosis. Remember that most patients will not have urogenital signs or symptoms. So they will not tell you, I have a sore throat, or I have pain when I defecate, or I have burning on urination, or I have a discharge. Most patients will be asymptomatic, and they will come in with a rash or with joint pains. And so please don't miss that, and don't think that because they don't have a discharge, they can't have disseminated gonococcal infection. The majority of patients will not have symptoms other than the DGI symptoms. Get blood cultures on everyone. In up to 70% of the cases, the blood cultures will be positive. Remember to do gnats on all the mucosal sites, throat, rectum, and urethra, or the vaginal site. Send gnats at all mucosal sites and send cultures from all mucosal sites. So gnats and cultures from all mucosal sites, and obtain blood cultures. That will increase the yield so you can get detection of gonorrhea, and hopefully one of the cultures will grow so you can get antimicrobial susceptibility testing, and that will tell you how to treat those patients. Usually, initially, the recommendation is 1 gram of ceftriaxone IV, and then once the patient starts getting better, the next step is you can downgrade it to an oral regimen, but by then you will have antimicrobial susceptibility testing, and so you will know exactly what to treat the patient with. So that's the good news. In most cases, the treatment of DGI is for 5 to 7 days. But if the patient has frank arthritis or meningitis or endocarditis, you may have to extend the treatment duration. But for most patients who don't have those manifestations, 5 to 7 days is adequate. You start with IV, and then you move to either a PO regimen or an IM regimen. Now, in patients who have frank arthritis, get some sample from the joint, send it for both culture and, if you can, gnats. But a lot of labs will refuse to run the gnats because they haven't done validation assays on joint fluid. And in the joint fluid, you can have a lot of PCR inhibitors. So if you can't get a gnat from a joint fluid, just send it for culture. The yield is lower, but it's better than nothing. So that's how you manage patients with DGI. Now, what is the future of GC diagnostics? The future of GC diagnostics is pretty bright. Remember now, and this is based on the 2018 data, that at least half the organisms that are detected in the United States are sensitive to all antimicrobials. They're sensitive to the fluoroquinolones, they're sensitive to the macrolides, they're sensitive to penicillin, they're sensitive to everything. Boy, wouldn't it be nice to be able to find out at the site immediately whether that the patient is infected with the organism and whether that organism is sensitive or resistant to different classes of antibiotics. Excuse me. Remember, cultures take 48 hours to 72 hours to come back, and then antimicrobial susceptibility takes a little bit longer even then. And so sometimes you have to wait 3 to 5 days to get the data that you need from cultures. So it would be really nice to be able to do it molecularly, right? Using a genetic test. Rather than grow the organism, you can just look for mutations. And that would be phenomenal. And in fact, you can look for certain mutations that predict decreased drug susceptibility to certain classes of antibiotics. The most consistent mutations that predict resistance to the class of antibiotics is for the fluoroquinolones. So finding mutations genetically highly predicts the likelihood that that organism will be resistant to the fluoroquinolones. Unfortunately, the predictive ability of genetic mutations to predict resistance to the macrolides and certainly to the cephalosporins is much less consistent. And so for the fluoroquinolones, it's great. For the macrolides and for the cephalosporins, it's not quite as good. So in the near future, you may find on the market a diagnostic test that not only, it's a nucleic acid amplification test, that not only tells you that the organism is present, so the patient is infected with Nyseri gonorrhea, but it will also tell you whether that organism is sensitive or resistant to the fluoroquinolone class. Why is that important? Because you'll know, you'll have options. If it comes back and it says it's sensitive to the fluoroquinolones, and for some reason you can't use Ceftriaxone, you can use the fluoroquinolones instead. And so in the near future, there will be diagnostic tests that give you some information about antimicrobial susceptibility. Of course, there are advantages and disadvantages to all of this. The advantages of these molecular tests is that the sensitivity is better than culture and that you don't need any viable organisms. You can have dead organisms as long as you have the DNA, you can test for it. And it can be automated and you can get the results very quickly. The downside is that you can't test for all antimicrobial susceptibility. Mainly right now, you can test for fluoroquinolones. Macrolide resistance genomically is more difficult to assess phenotypically. It doesn't correlate as well, and certainly cephalosporins don't correlate as well. So keep in mind that in the near future, particularly for fluoroquinolones, and that's going to be useful, right? If you see a patient, let's say Henry, our patient Henry, remember he came back and his test of cure for the pharyngeal gonorrhea was still positive. What do? If you were able to send a test that came back in the next couple of hours and told you that that organism is sensitive to the fluoroquinolones, then you could use the fluoroquinolones to potentially treat Henry. So there are significant advantages to have these tests available to us at the point of care. So point of care tests, molecular tests will likely become a reality in the next few years. And this is a study that was done by Jeff Klausner's group that showed that if you knew what the susceptibility pattern was through these rapid tests, you could act on it, and that would make a difference on the clinical side. So it's a nice, essentially, proof of concept. What is the future of GC therapy? I wish I could be more optimistic here. And unfortunately, a lot of the drugs that were targeting GC in the future, zoliflodacin, gepotidacin, azithromycin, delafloxacin, aztreonam, many of these drugs have essentially hit roadblocks. Zoliflodacin, for example, It had limited activity at the pharynx at lower doses. Again, gepotidacin also had pharyngeal efficacy questions. Delafloxacin was not reliable, and it only had about 85% efficacy in a phase 3 study. A recent open label study of estrionem by Lindley Barbie also showed very limited efficacy at the pharynx. So a lot of the drugs that we were counting on to come and save us for gonorrhea when ceftriaxone becomes essentially no longer active, a lot of these drugs have not had very successful runs in clinical trials. So that's a huge problem, and it's a scary problem. And so we don't have a lot of options in the near future. For patients who have ceftriaxone resistance, what was used in other countries were the carbapenems like ertapenem to treat those patients. Luckily for now, we are not seeing ceftriaxone resistance in the United States, but ladies and gentlemen, it's only a matter of time. So keep your eyes open and communicate with your public health department. Public health departments, local public health departments are so important. They're critical because they can tell you about your local epidemiology. They can tell you, listen, we're seeing a lot of gonorrhea in persons who use X or in persons who live in the zip code. That can certainly change your practice in terms of screening. Health departments also often will be phenomenal in providing the opportunity to do cultures. Remember, a lot of the big commercial laboratories will do culture testing, but some of the smaller laboratories will not do culture testing. And if you're stuck, call your local health department, and they often will give you information about where you can get gonorrhea culture testing. So they're important for epidemiology. They're important to find out where you can get certain tests done. And they're important as well because you need to report patients to your local health department that have gonorrhea. And please pick up the phone if you find anybody that has cephalosporin resistance. Immediately call your health department. What's the future of GC prevention? The good news is that a vaccine that protected people from Neisseria meningitidis was found to afford some protection against Neisseria gonorrhea. And that has revived the interest in vaccines for gonorrhea. In the next 5 to 10 years, I'm optimistic that we might have a vaccine for gonorrhea, but in the near future, it's not quite happening just yet. Keep your eyes open. In 5 to 10 years, I think we will have a vaccine for gonorrhea. It may not be 100% effective, but it will have some efficacy. What are the take-home points for gonorrhea? Most infected individuals are asymptomatic, particularly throat and rectum. All of them almost are going to be asymptomatic. So screen based on reported exposures, not symptoms. Self-collected urogenital and extragenital specimens perform comparably to clinician-collected specimens for NATS testing. So keep that in mind. You can ask the patient to get you a swab, a vaginal swab or a rectal swab or a pharyngeal swab, and that's very easy to do. NATs are now FDA cleared for extragenital testing and are much more sensitive than culture at those sites. Cultures are the only way to obtain antimicrobial susceptibility testing at this time. They're necessary when antimicrobial resistance is suspected. So make sure you know in your community who can do cultures for you. Disseminated gonococcal infection is a life-threatening condition. Examine patients carefully, obtain blood cultures, also obtain NATs and cultures from all mucosal sites. Keep that in mind. The treatment of complicated gonorrhea has changed. It's now 500 milligrams of ceftriaxone. If chlamydia is present, you can give doxycycline for 1 week. Alternate regimens only for urogenital and rectal chlamydia are Suffixine 800 milligrams or Genomycin plus oral 2 grams of azithromycin. Remember, for pharyngeal infections, nothing else other than ceftriaxone will do. Patients with pharyngeal gonorrhea should be treated with ceftriaxone. A test of cure should be performed 1 to 2 weeks later. Remember that a reported history of penicillin allergy should not make you want to abandon ceftriaxone immediately. It should make you want to ask more questions. And then remember to rescreen all persons diagnosed with gonorrhea in 3 months. So test of cure for pharyngeal infections, and then rescreen everybody that you treated with gonorrhea in 3 months, and treat all sex partners in the preceding 60 days of index patients diagnosed with gonorrhea. So there's a lot to do when you diagnose somebody with gonorrhea. Remember, you want to treat their sex partners, you want to bring them back in 3 months, and if they have pharyngeal infections, you want to do a test of cure 2 weeks after treatment. Ladies and gentlemen, this is a fantastic resource that's funded by the CDC. If you happen to be in the United States of America, any question that you have about the management of any STI, you can go to the NNPTC, the training centers, and go to this website, STDCCN. It is the consultation website. You enter your question, and within hours, you will have an answer from an expert in your area. It is free. It is funded by the CDC. It is available to all clinicians who practice in the United States. Please use this website. We get a lot of consults. We get great questions. It's a wonderful resource that's funded by the CDC. Post-test question number 1. Are you ready? It's the same post-test question. Everybody's going to get it right. A 38-year-old woman presents for a routine visit. Her physical exam is normal. She has a vaginal swab that's sent for gonorrhea and chlamydia. Her chlamydia is negative, but her gonorrhea vaginal swab is positive. What will you treat her with? What's the best regimen? A, B, C, D, or E? Everybody's going to get this one right. I can feel it in my bones. All right, let's see what you did. Yes, everybody got it right. Well, almost everybody, but you're absolutely right. It's ceftriaxone, 500 milligrams. The patient doesn't report any allergies, so you don't necessarily need to use Genomycin and Azithromycin. You could use it. Definitely not Suffixine 400. Remember, it's 800 milligrams for Suffixine. Definitely not Azithromycin. And Azithromycin plus ceftriaxone is no longer recommended. So it's ceftriaxone 500 milligrams. Wonderful. Well done. Our next and last post-test question, 23-year-old man, he's got pharyngeal gonorrhea. What do you need to do with pharyngeal gonorrhea? Ceftriaxone intramuscularly and treat the sex partner. Ceftriaxone, rescreen and treat sex partner. Ceftriaxone, do a test of cure and treat a sex partner, or everything. Ceftriaxone, pharyngeal test of cure, rescreen in 3 months, and treat the sex partners. Which one? A, B, C, or D? I know you're all going to get it right. Otherwise, you're going to break my heart. I can sense it. So many questions. We're going to get to your questions immediately. Yes, 94% got it right. You want to do everything. You want to do intramuscular ceftriaxone to treat them. That's the only regimen for pharyngeal gonorrhea. You want to do a pharyngeal test of cure in 1 to 2 weeks. You want to rescreen them in 3 months. And you want to treat all their sex partners in the preceding 60 days. It is the complete package here. Well done. Thank you very much for answering that question. And so let's keep going now. Is there more? Thank you. Yes, you are. And so now you can submit questions using the Q&A, and there are tons of questions that I'm going to try to answer. If a symptomatic patient is treated presumptively for gonorrhea and chlamydia prior to the test results and the results come back positive for gonorrhea, does the patient need to stop taking doxy? So it's absolutely feasible that you can ask the patient to stop using doxy if they only have gonorrhea without chlamydia. So yes, you can make them stop taking the doxy. It's perfectly reasonable. When will the entire 2021 STD guidelines be released? Yes, great question. They were supposed to be released in 2020, but because of COVID, ladies and gentlemen, the 2020 guidelines were delayed. They will be released by the CDC in the first quarter of 2021, meaning in either January, February, or March. The good news is there's a webinar that was done by the CDC. If you go to the CDC website, in the STD, they have a link to the webinar. That webinar was presented by Drs. Gail Bolin, Kim Workowski, and Laura Bachman, and they summarize the changes that are happening in the 2021 treatment guidelines. A recorded version of that webinar that was given in December is found on the CDC website. If you can't wait until the first quarter of 2021, go to the webinar website and review it. It's a wonderful 1-hour presentation by Gail Bolin, Laura Bachman, and the incredible Kim Workowski. Can you clarify? It says women who did not report anal sex tested positive at the rectal site. Should we be doing rectal and pharyngeal sites then for all women with risk factors? What a great question, Jamie. And the answer is, it is thought that the reason why the rectal infection occurs or the rectal positivity occurs is because potentially of auto-inoculation from the vagina, from the vaginal secretions into the rectum. So the counter argument that's made is, if it's coming from the vagina, then if you test the vagina, you're going to detect it anyway. Unfortunately, you're never sure if the rectal infection is just inoculation, auto-inoculation, or whether it is an exposure related. And so in women who report rectal exposures, I would screen them separately at the rectum. If they don't report rectal exposures, then I would just screen them at the vagina, and any self-inoculation should be detected from the vagina. The good news is that vaginal and rectal infections are treated the same way. Great question. Why is urine preferred for men for NAT testing, even though your table indicates that male urethra has the highest sensitivity? Mainly because although the male urethra may have a slightly higher sensitivity, slightly, for NATs over urine, first catch urine has very high sensitivity, and it's less invasive. Men hate for you to stick a swab in their urethra, and I don't blame them. And so they're less likely to come back to get tested if you do a urethral swab as compared to a urine. So a urine is easier, it's less invasive, patients like it, and it has excellent sensitivity. Now, you will need to do a urethral swab for culture because it has a much higher sensitivity. That's the only swab in men that is appropriate. It's a urethral swab. Thank you for that question. My center has been having trouble getting supplies for NATs because of COVID. Every center has had that same problem, and that has impacted our ability to do screening and testing for STIs. It's a mess of a problem. Hopefully that will go down in the near future, but it's a problem that we're all facing. One way to avoid it is to send urine for gonorrhea and chlamydia in both men and women. That's one way of bypassing it, but it's a huge problem. Given do we have a sense of how long the shortage will continue? A great question. The answer is no, but I'm assured that in the next few months, the shortage should become less apparent. I don't know if I believe it. The good news is, remember, you can send urine for gonorrhea, chlamydia testing in both men and women. And so that's your best option for testing. Some other labs have validated certain swabs that are not used for COVID testing. Call your lab and figure out if they've validated swabs that are distinct from the ones used for COVID. In some cases, some laboratories have validated swabs that are not being used for COVID testing. Thank you very much, Dr. Singh, for that question. Dr. Sokolov asked, is there any reason to think that doxy or azithro dosing should be increased for morbidly obese patients? And the answer is, for morbidly obese patients, you may want to consider increasing the dose, particularly of ceftriaxone. We already talked about that. If they're greater than 300 pounds, you have to use 1 gram of ceftriaxone. For azithromycin, there may be some data to suggest that increasing the dose in morbidly obese patients to 2 grams from 1 gram may be required. For doxy, I haven't seen that done. Mainly, we've always used 100 BID, but it's a great question. And I would ask your pharmacist about doxy and increasing the dose of doxy. Doxy has been safely used in the short term at the 200 milligram BID dosing schedule, but we haven't done that for morbidly obese patients, but I will check with pharmacy. It's a great question. Thank you for asking that. If you want, send me an email and I will answer that as soon as I get the answer from pharmacy. For chlamydia, if concerned about doxy course being completed, what is your opinion about giving azithromycin DOT and what dose would you use? So for chlamydia, remember, doxy is perfectly reasonable. It's an alternate regimen in the 2021 treatment guidelines. You can use 1 gram to treat chlamydial infections. So 1 gram of azithro is perfectly fine to treat chlamydia infections. Now, let me just highlight, there was a recent randomized controlled trial that looked at 1 gram of azithro versus 1 week of doxy for the treatment of rectal chlamydia. And it turns out that doxy was much more effective, like 20% more effective than azithro for the treatment of rectal chlamydia. So I would say, if you have a patient that has urogenital chlamydia, you can use doxy, you can use a gram of azithro, it doesn't matter. But if you have a patient that has rectal chlamydia, I would preferably use doxycycline. It is a better agent than azithromycin for the treatment of rectal chlamydia infection. Can you discuss empiric treatment of proctitis and urethritis for symptomatic patients prior to receipt of test results? Specifically, would you recommend doxy over azithro in these patients? Yes. So if I were to treat a patient with proctitis and I didn't have any test results back, I would use 500 milligrams of ceftriaxone, and I would give them at least a week of doxycycline. If they had severe symptoms, I would give them 3 weeks of doxycycline. And then once you get the test results, you can modify it. The reason why I would give 3 weeks of doxycycline is because in patients who have severe symptoms, in those patients who happen to have LGV as the cause from chlamydia trachomatis, data suggests that 3 weeks may be better than 1 week for the treatment of LGV proctitis caused by chlamydia trachomatis. So if they have mild symptoms, I would do doxy for a week plus ceftriaxone 500 milligrams. If I have somebody with severe proctitis syndromes, I would do ceftriaxone 500, and I would give them 3 weeks of doxy 100 BID. That will cover gonorrhea, chlamydia, LGV chlamydia, and it will also cover early syphilis with 2 weeks of doxycycline. So it'll cover everything. Thank you very much for that answer, Dr. Rahman. What is the rationale for keeping the azithromycin in the Gentlemycin regimen? The only rationale is that's how it was studied. And so as a result of that, that's what the clinical trial looked at. And as a result of that, you have to keep the azithromycin in the regimen. And so keep that in mind. The other advantage is if a patient has pharyngeal gonorrhea, azithromycin is not a terrible drug for pharyngeal gonorrhea at the high dose. So gentamicin is not that great. And so it adds benefit to the treatment, perhaps, of pharyngeal gonorrhea. So that's just an FYI. Thank you, Dr. Akande. Dr. Sokolov, another question. How do you counsel patients on cross-reactivity of severe allergic reactions to penicillin when using ceftraxone? So if the reaction is recent and is consistent with an IgE-mediated reaction, I will say, listen, I am not going to use ceftriaxone because it's a recent reaction and it's clearly IgE-mediated. I'm going to treat you with an alternate regimen. Usually I'll use Genomycin plus 2 grams of azithromycin. But what I will tell them is I think it's a good idea to go get skin tested because it will open up possibilities for us in the future. So I will refer them for skin testing. For most patients, though, they don't give you a great history. When I was a baby, or I get, I get a rash, in those patients, I usually ask a few additional questions, and then I will just treat them with ceftriaxone. If Suffixine cannot be used for pharyngeal infection, does this now require ceftriaxone for most partner treatment? Should the Suffixine be given presumptively anyway? So remember, you're seeing an index patient with pharyngeal infection. You don't know that their partner has a pharyngeal infection, right? And so yes, for EPT, it's still okay to use Suffixine 800 milligrams for the partner. It's okay. Of course, if the partner happens to have pharyngeal gonorrhea, then it's possible that the partner will not be treated. That's the downside now of, Suffixine. But the benefits of EPT, I think in this case, outweigh the lack of treatment in a small minority of patients. So by all means, continue to use EPT, 800 milligrams of Suffixine in those patients. Thank you, Dr. Tosiello. Dr. Kanuri, is a test of cure needed for chlamydial infections? No, a test of cure is not needed for most chlamydial infections. However, if you use azithromycin and to treat a rectal chlamydia infection, and the patient still has symptoms, you may elect to do a test of cure 2 weeks after the end of therapy. Jamie Winan has asked, regarding repeat testing of the pharynx, would the gnat stay positive for beyond 7 to 14 days, thereby requiring a culture to confirm eradication? So most gnat infections of the pharynx and of the urogenital tract will become negative within 7 to 14 days. That's why the risk of a false positive is low. It's certainly lower if you wait 2 weeks. I usually wait 2 weeks and bring them back for a gnat test. The risk of a false positive is very low, but it's also low at 1 week. So if you think that the patient is more likely to come back at 1 week than at 2 weeks, bring them back at 1 week. If you think that the patient, either one is fine, bring them back at 2 weeks and do a test of cure. The gnats should become negative in the vast majority of patients. Laura Bachman and others have done studies in the urogenital tract, which clearly show that by 2 weeks, the gnats are negative. Thank you very much. I just answered that question from Dr. Sachs before. Like I said, it may not eradicate the Suffixine may not eradicate the pharyngeal infections, but in the vast majority of partners, it will clear up most infections with gonorrhea, most mucosal infections with gonorrhea. So it's still worth using for EPT. It's not perfect, but it's worth using for EPT. If a test of cure is positive, what's the next step? So when you do a pharyngeal test of cure, if it comes back positive, the next step is to ask the patient, did you have another exposure? If the patient says, I've never had another exposure, then you want to get another gnat and a culture from the throat. Then you want to treat the patient, either 500 milligrams again of Ceftraxone, or you can use Genomycin plus 2 grams of azithromycin and wait for the culture and gnats to come back and look at the culture sensitivity. If the organism is resistant, call your health department and it will tell you what it's sensitive to. You can use that information to treat the patient appropriately. If you have any questions, call your local ID expert or send a question through the consultation network that I gave you the address to a little bit earlier. Thank you so much for that. For Brian Minalga is asking, how is DGI different clinically? Remember, with DGI, you are looking for certain clinical manifestations such as rash, particularly on the extremities, tenosynovitis, so pain at the site of attachment of muscles to the joints, joint pains, sometimes fevers, fatigue, malaise, listen to their heart if you suspect endocarditis. Sometimes patient may present with headaches, photophobia that may suggest meningitis. But the big manifestations are rashes, joint pains, and if it's frank arthritis, you will feel the joint and it will be warm and tender. And so those are some of the clinical manifestations that you should be looking for. And so I'm going to go to Dr. Sokolov. I just answered that question already. I'm going to go to Milana B. What do you recommend as alternative therapy in patients who are truly allergic to Ceftriaxone and have oropharyngeal gonorrhea, apart from Genomycin and Azithromycin? Do you recommend desensitization versus IV therapy with a carbapenem versus something else? So yes, it's a tough situation. And my go-to is Genomycin, is Azithromycin. You know, there are certain things that you can do to try and treat those patients. For pharyngeal infections, you know, you could consider a fluoroquinolone, but I would bring them back for a test of cure. So like Cipro, 750 milligrams, 500 to 750. But I would make sure to bring them back for a test of cure. But I would certainly send a culture when you see the patient to make sure that if you fail whatever you choose next, you will have something to rely on when the patient comes back. It's a tough question. Nobody has the right answer. I think a carbapenem is reasonable, but we have limited data on the use of carbapenems in pharyngeal infections with gonorrhea. So keep that in mind. Is rescreening in 3 months only recommended for pharyngeal gonorrhea? No, 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 no. It's recommended for all gonorrhea, for all chlamydia, for all syphilis, and for all trichomoniasis. You want, once you treat somebody, automatically give them an appointment to come back in 3 months because you want to rescreen them. And so it's recommended for all those infections, not just for pharyngeal. Pharyngeal gonorrhea, the only thing that's different is that you want to bring them back in 2 weeks to do a test of cure. That's the only difference. You don't have to do that for rectal or urogenital, but it's rescreening at 3 months for everyone. What is the treatment for chlamydia without gonorrhea? Is it now doxy? The preferred regimen will be doxycycline for 1 week, and if it's LGV with symptoms, for 3 weeks. And that is the preferred regimen. The alternate regimen will be azithromycin, but azithromycin is not a good drug for rectal infections. Keep that in mind, rectal chlamydial infections. Thank you very much. I've been seeing, Dr. Mo, Anita Mo is saying, I have been seeing Genomycin 240 milligrams IM as a single dose plus 2 grams as a single dose, but your slides are showing 5 milligrams per kilogram. So 5 milligrams per kilogram is the generic number. 240 milligrams is the number for most patients. If they're bigger patients or if they're tiny patients, 5 milligrams per kilogram is what's used. For most average size patients, 240 milligrams is a perfect number. Thank you for asking that. We have tons of Ceftraxone 250 milligrams vials in clinic. Yes, 2 vials can be mixed together as long as they're single-use vials. So you're absolutely fine in mixing them together. And that's perfectly fine. You can give the injection either in the deltoid or in the gluteus muscle. Either one is fine, depending on your preference and the patient preference. So talk to the patient about that. For screening and cost reduction, do you use pool gnats? It depends on the labs. Very few labs are using pooled gnats, but they do cut down on costs. A lot of places in resource-limited settings are using pooled gnats. And what they do is they put, let's say, 5 gnats together in a bunch, and they run one test. And if that test comes back negative, you know that all the gnats are negative. You don't have to worry about it. But if that batch comes back positive, then you test each one individually. So it can cut down costs, particularly in populations with a low prevalence of that infection. But most labs are not using pooled gnats in the United States. In resource-limited settings, they may be using them. For screening and cost oh, thank you. I'm sorry. That was a great question. Thank you, Martin. Folks who adamantly deny receptive anal sex, could anilingus be a pharyngeal GC-infected partner, be the mode of inoculation? Yes, it's possible. And so that's definitely possible. Less likely than anal sex, but still a possibility. There have been some studies that suggest that perhaps deep kissing may also increase the risk of pharyngeal infections, particularly studies coming from Australia. You know, it's possible, but certainly the most common exposures tend to be penile oral or penile rectal. Having said that, it's certainly possible. Thank you very much, Dr. Sayegh. Do you use Ceftraxone 1 gram as an alternative to 500 milligrams IM? So if I have a patient that, no, usually I use 500 milligrams IM. That's what I use. If I have a patient where I'm struggling, I don't have options, and they come back and they deny reinfection, and they have a persistent infection, I might use the 1 gram dose of Ceftraxone. But in general, I've only used the 500 milligram dose of Ceftraxone to treat most patients. Thank you for that question. If it's not feasible to repeat in 1 to 2 weeks due to travel, lack of care, how bad is this? Well, you know, if you use Ceftriaxone, it's not the worst. Just try to get them back whenever you can. I would not lose sleep over it if you use Ceftriaxone. If you used anything else, bring them back in 2 weeks. But in general, I wouldn't lose much sleep if I can't bring them back. I would try to bring them back. But if I really can't, if there's a huge hurdle, then I would sleep just fine at night, knowing that I use Ceftriaxone. When we screen with gnats, do we also send a culture? The answer is routine screening, no. If you're just doing screening, no. But if there's suspicion for treatment failure, or if the patient has DGI, then yes, you want to send a culture. So in two situations, if you suspect treatment failure, or if you suspect that the patient has DGI, then you want to send both gnats and culture. Thank you for that question. Also in cases of chlamydia infection in pregnant women, a test of cure is recommended, correct? So a test of cure had been recommended up through the 2015 guidelines, but if you're, for pregnant patients, remember the treatment of choice is azithromycin, and I'm trying to remember if the 2021 guidelines changed that. I don't remember exactly, but I suspect that they didn't change that. Ara, I am sorry, I can't answer the question for the 2021 guidelines. Keep your eyes open. When those guidelines come out, go straight to that section and figure out. I remember there was some change for the chlamydia. I just can't remember, in pregnancy. I just can't remember what it was. But for now, I would say if you're using azithromycin to treat chlamydia in pregnancy, and that is what's recommended, keep doing the test of cure. But send me an email. I have information that I can share with you about that offline. So send me an email. I'll look it up. Thank you very much for that question. I have multiple cases where urine for chlamydia and gonorrhea in males were sent to LabCorp and were negative. But when I sent cultures for chlamydia and gonorrhea to the state, the results come back positive. Ugh. Well, that's a tough one. So chlamydia culture is tough to do. And I assume you mean gonorrhea culture. You know, I can't explain that. I'll be honest with you. If they were sent at the same time, gnats have a much higher sensitivity than culture, and the gnats should be positive and the cultures should be negative. Here you're seeing culture positivity and gnat negativity. I think the most likely answer is something went wrong, either at LabCorp or at the state with the cultures, because it's really hard for me to find a reasonable explanation if you send those specimens at the same time. Usually, if you send both specimens, the gnats are going to be much more likely to be positive than the culture. It's just strange. So I can't answer your question with a definitive answer. I'm sorry. Thank you for a discussion of GC. Thank you very much, Dr. Jones. An expansion of the recent CDC guideline changes. Identification of opinions were given and refraining from becoming preachy. Beware of tyranny of guidelines. Yes. So listen, I think it's a very important point to remember that guidelines are meant to give you a path, right? Guidelines are meant to suggest the best approach on a population level. But decisions that you make on a patient level, on an individual patient level, are between you and your patient. And guidelines do not supersede that. So I think it's an important point. For the vast majority of patients, the guidelines are going to be spot on. But for a small subset of patients that you have unique characteristics, where their values are different, et cetera, then I think it's perfectly reasonable to tailor your approach to that particular patient. So thank you for highlighting that information. Ladies and gentlemen, I want to thank all of you for staying late. I tried to answer all your questions. If you have additional questions, don't hesitate to email me. I'm happy to answer them. I hope you have a wonderful new year, a healthy one, and I wish you the best of luck. Thanks very much for joining me.
Thank you, Dr. Ghanem. Evaluations and information on how to claim CME will be emailed by 5 p.m. Pacific time tomorrow, and this will enable us to review those attendees that have participated in today's webinar. Information about 2021 webinars is available on the ISUSA website. And as a reminder, this webinar will also be available on demand. A full listing of our upcoming activities will be located on our website. We have an upcoming virtual course on hot topics in HIV medicine, and this will take place in February 5th And lastly, our full listing of our ISUSA dialogue series is located on our website. Again, we'd like to thank Dr. Ghanem and to the audience for your participation. This concludes today's webinar presentation.